Welcome everybody to another ANZAD webinar. And I think I was chosen to introduce our guest speaker because I'm probably the only person who could pronounce her name. But I'm very excited to be presenting this art. I just want to do some housekeeping. Your sound should be through. Your speaker is unchecked. That's the little speaker at the bottom left of your screen. We won't be able to hear you, so if you have questions, please type them to the left corner of your screen. Lucene will be able to see the questions, and she'll also through her talk. We'll have some Q&A time at the end for her to address the questions. If you can't hear, there is a number on your screen which you're looking at now. You might want to take down that number. If you have a technical problem, you can call up. If the screen freezes or you can't hear, you might want to reboot by clicking the blue X in the top right corner. So I hope that's clear. All right, Lucene Wisniewski is Chief Clinical of the Emily Program, is an adjunct assistant professor of social sciences at Eastern University. From 2006 to 2008, he served as clinical co-founder of the Cleveland Center for Eating Disorders, a eating disorder treatment program. Research and clinical interests include using empirically founded treatments program. She provides workshops on the CBT and DBT treatment of eating disorders, international publishes in peer journals, as well as invited book chapters. Dr. Wisniewski has been a fellow of the Academy of Disorders and has served on the board of directors and as coach of the Disorder Special Interest Group. In 2013, the AED awarded Dr. Wisniewski the Outstanding Award to acknowledge her contribution to the field of eating disorder treatment. So I'm to Lucene Wisniewski.
Thank you, Anthea. I hope you can all hear me well. I really appreciate this opportunity to speak to this group. I'm going to, of course, this happens on cue. I was going to say, so I'm here at home because it's 7 p.m. my time, and luckily I'm not at work at 7 p.m. But that does mean that I am in my house with my 3 kids, my dog, and my husband. And so everybody has, strict orders to be quiet, but, you can't always predict. So now, of course, the dog is at the back door. And embarrassingly enough, I'm going to let her out, and then I'm going to text my husband and tell him that he should come get the dog. So hopefully it won't be too distracting. So when Anthea asked me to do this talk, there were several topics that were of interest to your group. Primarily the questions, because my expertise is DBT and CBT, that they centered around things like emotion regulation, patient ambivalence, and strategies for managing both of those. I thought that it might make sense to really focus on what DBT calls motivation and commitment, because they are the strategies associated with getting people motivated and committed to the work that they need to do to get better from an eating disorder really do use strategies that address ambivalence as well as emotion regulation. So today what I would like to talk about is some strategies for identifying the patients that you might work with that need work on motivation and commitment. Oh, and you can see here there's already a typo. It's motivation and commitment. Somehow we missed that one. To have some strategies to be able to, for the rest of today, because I believe it is morning time for you, to take away with you and perhaps do something different with the patients that you work with. So whenever I am speaking about a particular topic, I always, and especially one where There are terms that are used that I think are interpreted differently by different people, by different schools of thought. I always like to go to the dictionary because I want to start with a place that we are all talking about the same thing. So the first thing I did is when we talk about motivation, what does the dictionary say about motivation? So there's three possible definitions of motivation. The first is the act or process of giving someone a reason for doing something, the act or process of motivating someone. So for the example here is that some students need motivation to help them through school. So is that the kind of motivation that we're talking about when we're talking about addressing patients' ambivalence? And I think that that is probably one definition that would fit. The second is the condition of being eager to act or work, the condition of being motivated. Employees who lack motivation. One of the problems that I have with a definition like this, and you'll know this maybe from your own work, is if someone says they're not motivated, what does that exactly mean behaviorally? I will often say to my patient when they tell me that they're not motivated, I don't know where you get motivation. Do you go to the motivation store? How does that exactly work? So the second definition I have a little bit of a harder time with, although it's used clinically not infrequently. And then finally, the force or influence that causes someone to do something. There seems to be no motivation. And here the word motive is like reason to for the behavior. And I think that this is, again, a little bit more of an operational definition that we can work with. So when we think about motivational work, specifically, we are helping a patient becoming willing to work at change. I find that definition to be more concrete, more operational, which then helps us to be able to address this with our patients pretty directly. Again, my apologies. That's Checkers. She came with the name. She was a rescue dog, in case you were wondering. Probably not relevant to you that our President Nixon had a dog named Checkers. People always make fun of my dog for that reason. All right, so what are the indicators of a lack of motivation? When you say your patient is not motivated, are we talking about someone who's not showing up for session? Are we talking about someone in a CBT model who's not doing their homework, or frankly in a DBT model as well? Is this a patient who has failure to change? Are they saying they're not motivated? What do we mean? What are the indicators? So I want you to all, as we're talking about this, I want you to think about a patient that you're working with currently that you feel like, before you started this webinar, that you would say, yeah, they're not motivated. And think about what are some of those indicators that tell us that they're not motivated. Now the problem with when we say that what indicates a lack of motivation, there are lots of reasons for not showing up for session. There are lots of reasons for not doing homework. So for not showing up for session, it may be that you have a patient who has financial difficulties and it's getting in the way of their being able to get there. They're disorganized and they schedule their appointment for a time when they're working and then they realize they have to go to work. So there may be other reasons that are not actually an indicator of lack of motivation, but an indicator of something else. Not doing homework. Did they forget? Were there some other issues that got in the way, schedule-wise? Failure to change. They're not making progress. Does it mean they're not motivated? And also, one of the things that, again, I think is important that you'll see, because I'm not very good at holding back my punchline, because my punchline in this story is that you really need to assess people's motivation. You have to assess reasons for the behaviors that you're seeing that you think are a lack of motivation. Because when someone says they're not motivated, it is not uncommon that they have been told that they're not motivated, that if they're not making change, that someone said to them, well, you're not motivated enough, and that people internalize that, whether or not it's actually accurate. So the problem is, it may be that you have someone who you really strongly feel is not motivated, but they are coming to session regularly. They are doing homework. They are saying that they're motivated. but they're having failure to change. And my sense is that that's really, as clinicians, where this conversation comes from. The ambivalence and the problems are centered around a failure to change. In DBT, we have a construct called apparent competence, and that is a construct that describes an individual's behavior as seemingly on top of whatever it is they're doing, but underneath or internally actually not having the skill set that you think they do. A construct that I have been thinking a lot about that I've got coming out in a paper soon in a special edition, I think it's the Journal of Clinical Psychology, that Alec Miller, who's an adolescent DBT expert, put together, is a construct that I'm calling apparent compliance, that I think we see a lot in our eating disorder patients, where they say that they're motivated, they're doing their homework, they're coming to sessions regularly, and yet there is no change. So again, I want to put out there that your job as the therapist is going to be able to assess these behaviors and understand what the factors are behind why they're occurring, and not just assume that it's a lack of motivation. So, all right, so how do you increase motivation? So what I did was I almost always believe that if you look hard enough, you will find smart, competent people that have done a lot of the thinking and the work for you. And Kelly Kerner, you can see I have cited her at the top of this slide, is a dear friend and colleague of mine who wrote a book called Doing DBT. Published in 2012, and if you're interested in DBT, it's a really fantastic resource. It doesn't directly address eating disorders, but it does talk about using DBT, more generally. And what Kelly says is, if you're working with a patient who is difficult, and I'm assuming that if you're interested in someone who has emotion regulation difficulties and has ambivalence, that we're going to consider them difficult to treat, that the process here is that you want to assess, motivate, and move, and in that order. So you want to assess, where are you and the client in relation to where you're trying to go, and we'll talk about what that means specifically in a minute. You want to motivate. Does your client agree and is willing to go the route you propose under his or her own power rather than being dragged? And in this part of the treatment, you want to ensure collaboration, and then you want to move. Intervene to create as much movement toward the goal as you can. So I thought it would be useful to think about it pictorially, and I understand, since we have a fairly spread out group here, that this would be a good example to think about a patient who's in Darwin and wants to get to Christchurch. And that you are clear with your patient when you start out that that's where you want to go. You're in Darwin and you're trying to get to Christchurch. I'm going to shut the door. Excuse me 1 second. So I have a very noisy brood, and they're actually all musicians, and so I've told them they're not allowed to start playing the drums and the piano, but if you hear it, you'll know what it is. Okay, so they're in Darwin and they're trying to get to Christchurch. So the first thing you want to do is be clear, like, okay, look, I understand this from Jeremy, lest you think that I am a world traveler, because I have not actually been to Australia and New Zealand, although I would really like to at some point. That the direct route from Darwin to Christchurch is actually quite an arduous one, and you're going to need a lot of commitment and a lot of different kinds of modes of travel to be able to get there, which I think very much mimics what happens in the therapy relationship. Like, have you agreed on where you're going to go? And in eating disorders, we're talking about, you are here, you have this level of behavior. You are, for example, I have a patient that I am working with who I've just started working with, who has a lot of ambivalence about recovery and a lot of ambivalence, frankly, even about staying alive. And for me, if we're up in Darwin, now there's tons of targets She restricts, she binges, she purges, she has significant self-harm, and has had many suicide attempts. And as you well know, if you work with a population like that, you're not going to solve everything at once, but you do need to know where you're trying to get to. And in this situation, for me, Christchurch is an agreement that she is willing to stay alive, keep herself alive, and that she is willing to at least control her eating to a place where she's no longer medically unstable. And I have in my head the route that is going to take us from Darwin to Christchurch, and that is from where we are now to her staying alive and getting in control of her eating. Now, the problem is, if I don't articulate that with my patient, she may have a different route in her head. She may think, all right, listen, I need to go have a beach vacation before we do this because I know it's going to be really hard. I'll sort of go south, but I really need a break, and I'm going to have a beach vacation for a month before I even consider going to Christchurch. Now, if I don't know that, we are going to be in big trouble. And you probably all have had experiences with folks where you thought that you knew what you were each working on, and then you got stuck. And you're experiencing your patient as being ambivalent when really you have not done your job in terms of clarifying with your patient where you're trying to go and how you're going to get there in the first place. So according to this great chapter, Kelly Kerner suggests, don't move. You can't move until you collaboratively have agreed on a route. And in a situation like this, I might, not knowing Australia geography perhaps as well as I might, because I am American, and we Americans don't always study other people's geography the way that you do, is I might say to her, is there a way for us to find something in the middle? Can you go to Perth but stay only for a week and then get ready to move on again, even though you'd like to stay for a month? Can we collaboratively come up with a decision? And as a therapist, I have to be willing to be flexible in that way as well. I can't decide, in this kind of a model. Now, I won't say that, by the way, that this is the model for everyone, because there are some folks, I think, in my experience, that you do need to say, depending on where they are medically, how much treatment they've had in the past, and their ability to collaborate, it needs to be this way because it needs to keep you alive. But if a patient has come to me and has tried many things before, and they're going to now try DBT, and they're willing to make the commitment to me, I am going to be way more willing to collaborate and go a little bit more slowly in the hopes that, and again, you probably have all had this experience where our eating disorder patients are okay if you drag them. They're often not okay then if they have to make the decisions themselves. And this is really all about getting them to collaboratively decide with you what the plan is going to look like. So back to this slide, you can't or don't start to move until you have a collaboratively agreed upon route. Now in DBT, this can take 1 to 4 sessions. So whenever I am starting work with a new patient, okay, I'm just making sure there was a question, but it looks like Anthea has handled it. When in DBT you have 1 to 4 sessions with which to get this motivation and commitment, and you don't start therapy until you've gotten clear commitment. So in that example that I described to you, this is a patient who has had a multitude of treatment options, from individual therapy lasting a year to 2, to residential treatment, to inpatient hospitalizations, both medical and psychiatric. And it took, we did not start therapy until we spent a lot of time being really clarifying what the plan was. Okay, so how do you do that? How do you make these commitment strategies? The idea here is that your job is going to be to sell the treatment. If you work in a clinic where you don't have the option, I think it is not uncommon, at least here in the States, to work in an environment where you show up and there are patients scheduled in your office and it's just expected that you are going to see them and start therapy with them. In DBT, we make the assumption that both the patient and you have to make a commitment to each other. And so your job in those first 4 sessions is selling the treatment. And selling the treatment is both a change strategy and a problem-solving strategy. In this strategy, and we're going to talk about some of these strategies, so hopefully you'll be able to take some of them with you for the rest of your day, that the therapist conveys an understanding to the patient that what they're if they're going to go through treatment, it's going to be hard. Part of your job is to let them know this is not a piece of cake. This is not come in and put your feet up and talk for an hour and then you're going to be better. Because if it was that easy, you would already have done it. And that one of the things that we know both from clinical psychology, but really from social psychology, is that commitment to the task, whatever the task is a strong predictor of future performance. So if you're able to get commitment, and verbal commitment, frankly, is key, that the person actually has to say out loud, I am committed to X, that increases the likelihood of that person actually following through on the task that you've agreed upon. So that in DBT, there's a whole series of commitment strategies, and we're going to talk about some of them. So why is commitment important? I suppose I've addressed this a little bit, but when you enter into the relationship with a new patient, and in DBT, the idea is that you are engaging in a relationship that is between equals. It is not the doctor-patient relationship. It is a relationship of equals, that you want both parties to be on the same page, just as in any relationship. The patient agrees to treatment as the first step, but it's not going to be effective if they're not committed to treatment. And again, you know this, and you've seen patients like this where they say, yes, they show up, but they're not necessarily committed to the process. And that's why getting commitment as part of that first process is so important. Without it, you're likely to see early termination, you're likely to see frustration and burnout on your part as well as theirs. And one of the crimes, I think, that can occur without this sort of getting someone to be committed, and I really do see this as the therapist's job, right? It's our responsibility to elicit this from the patient, is that we need to make sure that we don't burn out and they don't burn out. Because if someone comes in half-heartedly and they start to work on something only half-heartedly, they're not likely to get better, and they may sort of lose steam before they actually see progress. And so we really want to make sure, and I will tell patients, I will use the metaphor of like, listen, if you're going to commit to me, I'm going to roll up my sleeves and we are going to attack this eating disorder together. And are you committed to doing that with me? So without commitment, you could be frustrated and the patient can be frustrated and burnt out, which is obviously going to be a problem for ongoing treatment. There's a question is what of the age of the patient? I'm really talking about adults here because I think that the issues with adolescents to me are just a world of difference. Partly because, at least in our center, we combine FBT with DBT with our very difficult to treat adolescents. And so the issue of motivation and commitment, I think, is a lot different. And perhaps at some point, you'll have me back to talk about motivation and commitment for adolescents. Okay. So my kids are now putting on masks and dancing in front of the windows. So maybe you'll see them through the reflection. Okay, the need to talk about it. People are more likely to keep commitments they believe in, right? So your job is to actually talk about it with your patient and to have them articulate why are they going to make this commitment? What is the point? So you want them to rehearse the good points of the solution and to also be thinking about what are going to be the counter arguments that you're going to come up with, because you know that once they leave the session, they're going to get ambivalent. meaning they're going to start to have doubts about what, the commitment that they're making. So if I'm going to, for example, in the patient that I've been using as my example, I am going to say to her, okay, listen, you want to stay alive, that's great. You want to, she would like to have more normal eating. She tends to vacillate between severe restriction and then binging and purging. I imagine that once you leave here, although it seems good right now, you might think, ugh, but what happens if I gain weight? Are you thinking about that? Yeah, all right, so maybe we better talk about that. What's going to happen when you leave here and you start to think, I don't know if I want to do this. It's going to make me gain weight. How are we going to think about it? So I'm going to think ahead about what I think their reservations are and help them develop some counter arguments to it before they even leave my session. And one way to do that is by doing pros and cons. Now, pros and cons really are a standard in cognitive behavioral therapy, and it's no different when you're doing DBT and you're trying to get commitment to a particular, whether it be to the treatment itself or to a specific behavior that you want a patient to change. So the keys here are that you want to highlight the pros and cons of committing to change, but you also want to highlight the pros and cons of not committing to change. These are not the same things. And it's important to remember that you want to get your patient to articulate both ends. You want them to be able to talk about both. And your job as the therapist is to relate their commitment to change to whatever the patient's life patterns are, what are realistic expectations for the future. So with my patient, I'm not expecting that she's going to be, she's actually has not made it through a semester of university since she started. I think she's 23, and she's been trying to go to college since she was 19. She hasn't made it through a semester, and I'm not going to necessarily expect that she, all of a sudden, just because now she's in therapy, miraculously she'll be a college graduate, in a short period of time. But we may be trying to work her to get her through to get through one class for an entire semester. So realistic expectations are going to be linked up to her commitment, because if you make a commitment that is you have them expect too much, then that's going to be a problem. And in this, you want to link up their commitment to the rationale of therapy and what they can expect. I think that that's also very important, especially for our folks that are more chronic. It is not going to magically make their life better perfect, but there are going to be likely positives associated with it. So I think that those are part of doing pros and cons. Now you can see my little dancing devil in the corner. One of the other DBT strategies is something called devil's advocate, which is where you're making arguments against making a commitment. Are you sure you really want to do this? Are you sure this is good time for you? You have a lot going on right now, and it's going to take a big commitment. And I'm going to be asking you to do homework every week, and it's going to be tough. Now, you of course don't want to make your arguments too strong. Geez, I really think you shouldn't do this. I think now is not the right time. You really, you're actually too sick to do this right now. You certainly don't want to do that, because you want to increase commitment. And one of the things that you can do here is that once you get a tentative commitment, you can ask for more. Okay, you can strengthen or increase the commitment once you get it. So, for example, if I asked someone, are you willing to gain some weight? And they say, yeah, I'm willing to gain some weight. And I might say to them, okay, are you sure? Because it's going to be really uncomfortable. So I'm going to play a little devil's advocate there. Well, I know it's going to be hard. Yeah, are you willing to gain 10 pounds? So I might up the ante once I do that. And this is the way to strengthen the commitment. So you get them to agree to a small, and this is actually, it builds a sense of control, and this is actually something that we call a foot in the door. You make an easier request first, followed by a more difficult one. Okay, and this is all actually one of the things that I love about Marsha Linehan is that she has basically taken from psychological research really many important constructs that have data behind them and incorporated them into her treatment. And the commitment strategies actually are taken from social psychology, where they are where they've looked at basically traveling salesmen and the strategies that they use to be able to get people to buy their dictionaries or encyclopedias. I don't think people do that anymore, vacuum cleaners. And so here, foot in the door is make an easier request first, followed by a more difficult one. So will you agree to gain some weight? If you can get an agreement there, then it's, will you agree to gain 10 pounds? So then the other end of this, and I don't know if it's not going to work. It has a little sound that shows the door slamming, which I quite like, is another commitment strategy. You want to request something much larger than you expect, and then request something easier. So for example, you might request that the patient not purge for an entire week. And if she says, I can't possibly do that, then you might back it up to that she call for coaching. And in DBT, we have telephone skills coaching is one of the strategies that's used. That patients have access to you outside of session, and you request that she call for coaching prior to engaging in purging behavior. So you went from something that was large, and maybe you didn't think that she was going to be able to manage that was too big, depending on the level of behavior she starts out with, and then you're willing to back it up to requesting that she call for coaching before engaging in a behavior. So you're not expecting that she has no behavior, but it's still a change in her behavior. We hope that she'd be a little bit more skillful. This may be especially useful for commitment to either doing their homework or for trying something new. Another strategy is something that we call freedom to choose and the absence of alternatives. And the idea here is you want to enhance the feeling of choice while stressing that there's a lack of alternative ways to achieve the patient's goals. So when we talk about freedom to choose, and you can really, one of the things that I love about these DBT skills is you can use them with your children. I'm whispering because I don't want my children to know that that's what I do for them. But this is, you have the freedom to choose. If you want to be able to go out this weekend, you do need to finish that project. You do need to clean your room. You have the freedom to choose, but really you have the absence of alternatives, because if you want to go out this weekend, you need to do the things that I set out for you to do. Likewise, with your patients, you want to discuss the natural consequences of their choices. You can choose to not do DBT treatment. You can choose not to do treatment like right now. But in the case of someone that you're trying to convince to do DBT treatment, you might note with them that they've tried other treatments and they haven't been successful. Or you can note with them that they could go somewhere else to get treatment. One of the things that for us, at least here in Cleveland, Ohio, there is no other place to be able to get DBT treatment for their eating disorder. So although they have the choice, it's the absence of alternatives. And I think that this will really, when used correctly, what this does is it really helps free you up from a power struggle. And I did actually use this with one of my kids this morning. I highly recommend it. You want to go out this weekend? You need to study for that test. So getting commitment to treatment may require the use of more than one technique, right? It'd be crazy for us to think that if you only use one of these techniques that it would be enough with our patients who are ambivalent, have emotion regulation difficulties, and are difficult to treat. So you may need to combine them. So sometimes what you might do is you might use foot in the door and door in the face. Present a goal somewhat vaguely and favorably, and then build from there. You need to elicit commitment to reach the goals. And again, I highly, highly recommend that you ask your patients to confirm their commitment verbally. Okay, so tell me again what you think we're committing to. I must do that 10 times a session, especially at the end of the session when I'm reviewing. And I would say this, even if I was doing CBT treatment, because I do both over the course of my day. I will say, okay, remind me again, tell me again what you're committing to, what your goal is, and tell me what you're going to work on for homework between now and when I see you next. And I have them say it back to me so that, number one, I'm clear that they are, that we're agreeing to the same thing, and number two, that it's part of getting that commitment for them to say it out loud. Okay, I'm just going to pass over that one. So once in treatment, you may need other commitment techniques. And, you know, so first I was talking about getting people to commit to treatment. So people that might be ambivalent to treatment in the first place. But then once in treatment, you may need to use either those commitment techniques or others. And I like to say some individuals need ongoing commitment work. You know who they are, right? You could probably think, if I asked you to think right now, who are the people on your caseload that need ongoing commitment work, you probably could be able to rattle it off the top of your head, because those are usually the folks that give us a lot of pause and we spend a lot of time thinking about outside of session. So I want you to take a minute for yourself and list the ways you notice wavering commitment in your patients. For me, there's a couple. Let's see if I have it on this next slide. No. Okay, for me it's not doing homework. Okay. Now again, I have to assess and make sure that that's why homework's not happening. And it's also not having an agenda of their own. That to me is often a very key indicator that that they are wavering in their commitment to behavior change. Because if they had a more clear sense of what they wanted to work on, I think that's an indicator of commitment. So what do you do when you have someone and you think, okay, they're not really committed to treatment? The first is that you want to connect their present commitments to prior ones. So if you've done your work well, okay, you have addressed at the beginning of your therapy with someone, what are their goals? Now I do this pretty, and again, I do this whether I'm doing CBT or DBT. I have a piece of paper. I mean, this is not very sophisticated, okay, but it's a very important part of my work with my folks. It's like my insurance policy. So when someone first comes in to see me, I will have them list out a minimum of 3 goals that they say they want to work on. And they're often not eating disorder goals, right? They're like, I want to get through college. I want to have a better relationship with my partner. I want to, you know, understand myself better, and that, and I'm just noticing that Anthea is posting for you to start to think of questions, because I am going to talk to 7:45 and then be open for questions. But so if I have this list of 3 goals for the patient, now of course there's also eating disorder goals always. But that's not often what is motivating the patient. It's the life that they want to have that motivates them to want to change their behaviors. Is that I want to link up with them the goal, what's going on right now, with what they've committed to in the past. And it's especially useful when there's a crisis. You know, when someone is not doing as well, when someone might be failing in their behaviors, when someone is perhaps in a situation that is dangerous or threatening, that you want to link it back up. Okay, hold on. I thought you agreed, for example, to not kill yourself for the next year. You committed to that. I take that commitment seriously. I thought you really wanted to finish this semester at college. How is your choice to not increase your daily calorie intake linking up with that, given that you in the past lose weight during the semester and end up having to take a medical leave? How does that link up? So so that connecting what's going on right now with their prior commitments can really be a strategy that's useful during the course of treatment. Now, and so some of the language that you want to bring up in a situation like that is, hey, wait, I thought you had agreed that you weren't going to kill yourself. Hey, look, I want to check. I know that you told me in the past that getting through university, getting through a semester was important for you. Is that something you're still committed to? So I think the important thing here, because these folks usually have such problems with emotion regulation, is you don't want to mind read. You don't want to tell them what they're thinking. You don't want to infer from their behavior. You want to ask. And you want to clarify the current commitment. Well, what are you committed to? And this is something with the patients that I work with. I tend to have this conversation. I'm going to say, if they're not getting better, this is something that I will not get off of until we've reevaluated what their commitments are and what we've renegotiated. So I have a patient, for example, that I've worked with for over a year in DBT, and has stopped self-harming and hasn't had a suicide attempt in a year, which is great, but her eating disorder is still really problematic. And we have been working now together for, I think, about 6 weeks, trying to get to a place where she can articulate what she wants to work on, and that if at the end of this time together, if we've decided that now that she's stable in her suicidality and self-harm, she doesn't want to work on anything from her eating disorder, we may decide that, to take a break from treatment, and that she could go talk to somebody else who's willing to not address her eating disorder, but it wouldn't be me, because as an eating disorder therapist, it would be too hard for me to be able to sit with her and not address. So that focusing on recommitment is an important part of that process, especially when you're not seeing progress. Focus on recommitment if the goal is essential to treatment or the therapist's limits. This is something that I will do with patients when, especially when I'm seeing a increase in eating disorder symptoms. Are you? I'm noticing that we're getting a bunch of questions, so I'm maybe a little bit distracted. So that I might focus on recommitment if the goal is essential to treatment or the therapist's limits. So can we recommit to your going to a higher level of care? For example, as your weight is going down, we need to readdress this. Renegotiate commitment if changes don't conflict with treatment or the therapist's limits. I'm going to keep going here so that I can make sure that we get through this, because we only have a couple minutes before questions. And then when we talk about freedom to choose, you must clearly present the realistic consequences of particular choices. One of the, I think, the mistakes that many novice therapists make are inflating the potential consequences of behavior. And I think that patients will learn pretty quickly that, whether or not, if you're suggesting that something's going to happen that's not. So if someone is not medically unstable, for example, but losing weight, saying that, well, if you don't choose to turn your eating around, that you're going to die imminently. I've seen new therapists do that without the data behind them. Obviously, eating disorders is one of the most, has the highest morbidity and mortality behind it. But I think that there are times where we might overuse that strategy. So finally, I just want to say that one of the other ends of helping people who are in an ambivalent place and having trouble committing to treatment is cheerleading. Patients need hope. It's really difficult to commit without hope, and that there are many times where you need to carry that hope for your patient because they're hopeless. They've had a lot of treatment and it hasn't helped, and that your cheerleading and sort of being hopeful for them really is relevant and necessary. And the idea here is that the patient has within her everything she needs to solve the problem. And if you don't believe that, this is where, sort of having a consultation team, and that's what we do in DBT, to be able to have your peers help you find a way to be able to believe that is going to be key, because we're going to assume that people have it in there. You just have to help them find it and access it, and learn new skills at the same time. The other way that commitment strategies are useful is around homework. You need to use all of your strategies to get people to do homework. And don't forget to check on progress, because if you ask them to do homework and then you don't follow up on it, it's not likely that they're going to continue to do that work outside of session, which is so key. And I thought it might be useful if people are interested in getting more training. None of these directly benefit me. These are 3 different organizations that provide DBT training. Behavioral Tech is Marsha Linehan's group. Their trainings are more live trainings, in-person trainings. TIC, which is Helen Best and Sherry Manning, they do online trainings of very high quality. I've done several trainings for them on DBT and eating disorders, and I think you can even get them, because they're on some sort of cloud-based place now. You could probably even get access to them if you wanted. And then Practice Ground is Kelly Kerner's group that is internet-based as well. And they're all actually excellent training opportunities if you want to learn more about DBT. So I pretty close, just a couple minutes over 7:45. Anthea, do you want to, are there questions are there themes, or should I just read them and answer them? What do you think would be best?
It'd be better if you start addressing the questions that are already on the screen, and then if people want to write more.
Great.
Or in themes.
Okay. So there's the first question: what if a patient won't commit to anything because of hopelessness, but they keep coming to sessions? Now, again, this is key. Now, we're back to assess. Okay, if a person is hopeless, and so therefore won't commit to anything. Now, I don't know what anything means, so Julianne, you might want to add to your description, but one of the things that I would do is, number one, I would wonder whether or not depression would need to get addressed first. Are you willing to work on the hopelessness, because maybe the hopelessness is really what's getting in the way of being able to do anything else? And if they're not willing to work on the hopelessness, they're willing to do something, they're willing to show up. So I think I would really wonder about that and see if I can get really concrete about something that they want to change, because there are great empirically founded treatments for depression: behavioral activation, cognitive behavioral therapy, and if hopelessness is the key problem, I would be targeting that as well. Now, I don't know if that answers your question, but I would not continue to see someone if we weren't committed to working on something together. If there was nothing that they wanted to work on, I would recommend that they go away, get some clarity, or take a break. If we worked on discussing it, we still couldn't come up with something that they wanted to work on, then I would suggest they take a break until they were more ready to make a change. But I would exhaust my options before I got to that place. Hopefully that addressed your question. And if not, you'll add in there. There's another question. Can you speak to your use of mindfulness with your work with patients with eating disorders? This is always something that comes up. I think there's a lot of interest in our field. In fact, I don't know if it was the last ICED or the one before. I gave a review talk on the use of mindfulness with eating disorder patients. And it's really interesting to me, both the interest and the mixed information that there is out there on the use of mindfulness. So I'll tell you, there's several things. First of all, I love mindfulness. Mindfulness can be useful for, just understanding what's going on inside. Many of our patients have alexithymia. They can't identify their emotions. They confuse emotions with sensations. So hunger and fullness are not always clear to them. Emotions are not always clear to them. Mindfulness is useful in those things. That being said, depending on the diagnosis of the patient, the use of mindfulness is very different. So there are some data to suggest that mindfulness is a useful intervention in and of itself with binge eating disorder. There are a couple randomized controlled trials and a lot of open trials using a mindfulness-based treatment for binge eating. And you can imagine, it makes intuitive sense, right? Like where it's more of a mindful eating intervention, which to me makes intuitive sense for the use of binge eating, for the treatment of binge eating. Jean Christeller, I can't remember who the other person is, but did some trials on that and showed it to be successful. Now, when we talk about anorexia and bulimia, I think we've got a different set of circumstances. And we had done, our lab did a study where we offered people blueberry coffee cake at their normal snack time during, these are people who are in a partial hospital program, and we counterbalanced. One time we asked them to use a mindfulness strategy, and the other time we asked them to use distraction, which is way more common in eating disorder treatment facilities, right? Like where they're doing crossword puzzles or word find, some sort of distraction. And these are obviously people who are moderately ill enough that they're in a high level of care. And then we compared, and we did the same thing with a group of college students. And what we found was that the college students had less distress and were able to identify their sensations better when they were more mindful, when they used the mindfulness intervention, than the distraction. And the complete opposite was true for the eating disorder patients. Now, again, these are that they were more distressed when they were mindful than not. Now, again, this is I think a really complicated topic, because someone might suggest, well, that actually maybe that will act as an exposure for the patient, because of course they're anxious. But my belief is that there's a place and time in treatment for the use of mindfulness, and it may not be when someone is sick enough that they're needing that level of intervention, when they're in a higher level of care, that it's more it's going to be more helpful when they've graduated in more of an outpatient setting, because of the distress involved. You can't really get in the way of their ability to take in what they need to take in at that place. But again, this is still early in data collection around this sorts of topics, so I'd be interested if people know of other studies like the one I described. Would you like to further discuss foot in the door, door in the face in relation to authenticity? Now, I'm not sure if I know what that means, but I will say that in all of DBT, you are authentic. I mean, and so I think maybe I do understand what you mean by this, is I never use a strategy purposefully in a sort of, I don't know, I don't like the word manipulative, but in a manipulative sort of way. I will say to someone, listen, I'm going to ask something big here. I don't know if you can do it, but I would really like it if you could commit to not purging at all. I know that that might be hard for you. Can you do that? And if they say no, then I'll back it up. Well, are you willing to call me before you purge? Or I'll say, I know that making any sort of commitment is a big deal. Are you willing, if you come in, are you willing to gain some weight? If you're going to eat more normally, that's likely going to be what's going to happen. Are you willing to do that? Oh, okay, you're willing to do that. Do you think you're willing to gain 10 pounds? So I'm really authentic about the way that I deliver it, and I'm really careful to not come off as a salesman. So here we go. So I think that this person put another comment here, is remember theories from first year and thinking them to be interesting, cool, but sneaky and manipulative. Does it feel that way? Get the whole parent thing, but not sure I want that to be feeling that way. I do with my 4-year-old, feel tricky with clients. But you know what? I don't feel like it's tricky. I really do feel like it's genuine. You are fighting with the eating disorder, right? The eating disorder is absolutely being tricky, and you need some strategies to be able to negotiate with the eating disorder, which is a very strong foe. And so I hope that the way that I just sort of modeled that helps you to see how I think about it, because I really don't, I think it's very important to not feel tricky or manipulative when you do it, to really find a way that's genuine. So hopefully that was evident in the way that I role played it. What is your outcome data like when this treatment is offered as their first treatment attempt? We don't offer DBT as a first treatment attempt usually. What we do is we offer it to people who have, hang on, sorry. Here we go. Are you hearing that? I've turned on music. Okay. We offer this to people who are have had multiple treatment failures in the past, that treatments haven't helped them, have significant emotion regulation difficulties, who may have a borderline personality disorder, and or have been in our CBT treatment and have had significant therapy interfering behaviors. The people who are storming out, the people who are hiding food, the people who are, throwing up in the bathroom, the people who are doing things that in most other treatment facilities get them banned, those are the people that we see. So it's very rare that we start out with this treatment, because I think there are lots of other empirically founded treatments that are less intensive and have data behind them. I think that's all my questions. Oh no, are there more questions, Anthea?
No, I think that's about it, and we're almost out of time. So,
yeah, perfect.
And that has last minute. People usually have appointments on the hour, so let you back
sure,
and get you family and your dog. And just to say thank you very much.
My pleasure.
Okay.
Thank you. All right, take care.
Close.